بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is a new lecture dealing with diagnosis of diffuse lung disease using the high resolution CT. Actually, I have a previous lecture in this topic, and according to the recent advances, I have made many of the changes in the previous lecture, and I rearranged the topic so that you can have it in a more simplified form, and also it covers many topics that have not been covered in the previous lecture. This lecture is divided into three parts, and I will start the first part by some of the introductory knowledge. Then we'll follow the differential diagnosis of the diffuse lung disease. Actually, you know that in order to interpret the chest X-rays, you should have number one in optimal quality radiograph, and the patient data are very important in this particular domain. And also, if you have the previous films, they will be benefit in the enriching the diagnosis and the follow-up of the disease. To start with, whenever we are talking about interpretation of the chest X-ray concerning the pulmonary parenchymal disease, we have to discriminate between two main topics. The first one it is the focal lung lesion, which means that you have a lesion or two or three lesions in the lung, and the rest of both lung fields are clear. By diffuse lung disease, we mean that we have an extensive pathology involving most of the pulmonary parenchyma in both lung fields. This is the difference between a focal lung lesion by CT and diffuse lung disease by CT scan. You know that the one of the basics for the evaluation of the diffuse lung disease is to have the high resolution CT scan, and this is the difference between conventional CT and high resolution CT. If you look carefully here, and you see that there is some bronchiectatic changes here, and these are not clearly visible. Also, if you look carefully underneath the pleural, you can see many reticular opacities which are not clearly demonstrated by the conventional ways. This is also another example comparing the conventional CT and high resolution CT. Here you are able to see bronchiectasis. In here you cannot see. Also here you can see the fissure. This is not clear in the conventional CT. Also, whenever we are dealing with high resolution CT, many times, especially in old people, and you can see some opacities in the dependent parts of the both lung fields. And this is not a disease, but it may refer to accumulation of some of the secretions in the dependent parts of the lung. Then, in order to exclude the possibility of being in a disease, you may have a bronch film, a bronch scan. In the bronch scan, and you can see that the opacities have cleared, denoting that they are not true lesions. And this is one of the ways in order to differentiate between pathologic opacities in the dependent parts of the lung and physiologic opacities, let us say so. And another way is to have what's known as expiratory CT. This patient in respiratory CT shows almost normal finding, and this patient has severe asthma. The expiratory CT shows significant areas of air trapping, and this cannot be appreciated in the expiratory CT scan. Then you know that we have four lesions in the focal lung diseases, which are the nodule, the mass, the patch, and the cavity. In the diffuse lung disease, we have four patterns of lung pathology, including the reticular pattern, which means that you have too many linear opacities scattered throughout the lung. The alveolar pattern, which means that you got patchy opacities with or without internal air bronchogram. The nodular pattern or the miliary pattern, where many micronodules are scattered throughout the lung field. And finally, the cystic pattern, where you can see multiple air-filled cystic lesions scattered throughout the lung. Then compare this with the normal lung parenchyma, which is seen here. Then we have an extra pattern, which is known as the ground glass pattern. And by ground glass pattern, we mean that there is diffuse veiling and increased density of the lung parenchyma with preservation of the bronchovascular markings. And to appreciate this pattern, you can compare with the normal lung here. You can feel easily that this lung is more opaque and shows many of the faint known as ground glass opacities. And this is what I mean by the cystic pattern of the diffuse lung disease. And this an example of the nodular or the miliary pattern of diffuse lung disease. Whenever you are dealing with any chest radiograph, the clinical data are very important. And especially in the diffuse lung disease, we need the clinical data. Very importantly, we should know if the patient had fever, had hemoptysis, if he is smoking, a smoker, or if he is exposed to certain substances like dust and allergens, for example. Then we should look for the distribution of the lesions, whether they are in the periphery of the lung or in the central part of the lung or both, whether they have a lymphatic distribution or random distribution, and what is the pattern in relation to the distribution. Miliary pattern with lymphatic distribution or miliary pattern with random distribution. Then look for associated imaging findings like the presence of mediastinal lymphadenopathy. This is very important in certain diseases, and also the presence of pleural effusion. Then one of the important issues is to look for the chronicity of the disease. And whenever you look to the chest radiograph and you consider that the outer 3 to 4 centimeters of the lung are those which are referred to the peripheral part of the lung. And this peripheral part of the lung and the 3 to 4 centimeter applies also for the lung adjacent to the fissure. The lung adjacent to the 3 to 4 centimeters adjacent to the fissure are also considered the peripheral lung field. Then one of the major issues here is what is the pulmonary lobule. The pulmonary lobule is a hexagonal structure which is located immediately in the subpleural area, and this lobule contains the centrilobular artery, the terminal bronchiole, lymphatics, and veins. The distribution in relation to the lobule is very important in assessment of the different patterns of diffuse lung disease. And the secondary pulmonary lobule is a polygonal structure composed of acini and terminal respiratory bronchioles. The number of acini in each lobule ranges from 3 to 20 acini according to the size of the lobule, which ranges between 1 to 3 centimeter in diameter. Then lymphatic distribution means that the opacities or the disease is spreading along the bronchovascular bundle, the interlobular septi, and the major and minor fissures. At a time, it will be very difficult to you to assess this distribution because of the overlap of the opacities. But I will explain to you how to handle this, which is very important so that you can reach the final diagnosis. This is a good example of lymphatic distribution. If you look carefully here and you see that there are interstitial opacities, and these opacities uh, is spread throughout the lung. And if you look to the side of the fissure, and you can see that the fissure is thick. And this is one of the leading criteria to know that you are dealing with the lymphatic distribution is to see that the fissure is thickened, and also if you see nodules along the course of the fissure, and this is very important to judge that you are dealing with lymphatic distribution of the opacities. If you know that you are dealing with lymphatic distribution, what are the major possibilities of this disease or this distribution? They are four: pulmonary edema, lymphatic interstitial pulmonary edema, sarcoid, which is very important here, lymphangitis carcinomatosa, and lymphoma. Now we'll start the differential diagnosis of diffuse lung disease, starting by the reticular pattern. If you look to the chest radiograph and you see too many reticular opacities or strandy opacities involving most of the lung fields, what are the possibilities? And here are the possibilities. Number one, interstitial pneumonia, including two major types: the usual interstitial pneumonia and the non-specific interstitial pneumonia. Number two, interstitial pulmonary edema, idiopathic pulmonary fibrosis, collagen-related interstitial lung disease, drug-induced interstitial lung disease, and radiation-induced interstitial lung disease. We'll start by the two most common causes of interstitial lung disease of the idiopathic form: the usual interstitial pneumonia and the non-specific interstitial pneumonia. Both can produce similar findings, but honeycombing, I will explain, is common in usual interstitial pneumonia and uncommon in non-specific interstitial pneumonia. The prognosis of the usual interstitial pneumonia is bad compared to the non-specific interstitial pneumonia. Then usual interstitial pneumonia is a histologic diagnosis, represents lung reaction pattern to an injury. If this is idiopathic, it is known as idiopathic pulmonary fibrosis, meaning that if there are reticular opacities, honeycombing, traction bronchiectasis without a known cause, then this is known as idiopathic pulmonary fibrosis. But if there is a predisposing factor like exposure to dusts, exposure to drugs, or the presence of a collagen vascular disease, then this is known as the usual interstitial pneumonia secondary to these factors. Then clinically, this is a disease presenting by progressive shortening of breath and a non-productive cough. The symptoms are usually present for more than 6 months, and the presentation is usually over the 50 years of age. Women are affected slightly more common than men, and this disease does not respond to steroid therapy. The prognosis is poor with median survival less than 5 years. Complications of usual interstitial pneumonia include accelerated progression, lung cancer, and superimposed secondary infection. Then how can you diagnose usual interstitial pneumonia by high resolution CT? And there are two major issues. Number one, extensive interstitial opacities throughout the lung, usually in the periphery and the lung bases, as well as honeycombing. And by honeycombing, we mean multiple small cystic areas containing air with a thick margin located in clusters in the subpleural location. And this is a good example for honeycombing. Also here you can see honeycombing and there you can see honeycombing. Interstitial septal thickening, interstitial opacities everywhere, and ground glass opacities which are almost present in any of the diffuse lung disease, ground glass opacities. But we have a specific differential diagnosis for the ground glass opacities if they are present alone in the lung. Then the lung volume will be decreased due to fibrosis unless the patient develops emphysema. The lung will expand. One of the major issues here is the presence of traction bronchiectasis due to the fibrotic reaction pulling on the wall of the bronchi. And this is what we mean by honeycombing clusters of cystic air spaces. The average size is between 3 millimeter to 1 centimeter. They are well defined with thick wall and they are predominantly present in the subpleural area. This is an example of usual interstitial pneumonia where you can see ground glass veiling, you can see honeycombing, you can see traction bronchiectasis, and many of the interstitial opacities. Once more, this is the usual interstitial pneumonia. If no known underlying cause, it is called idiopathic pulmonary fibrosis. And you can see the typical appearance, interstitial opacities, honeycombing, traction bronchiectasis, and the ground glass veiling. Then the non-specific interstitial pneumonia is relatively mild compared to the usual interstitial pneumonia. It presents with progressive shortening of breath and non-productive cough, but the age is relatively younger. Men are slightly more affected than women, and this disease responds to the corticosteroid treatment. Then you can see all the manifestations of usual interstitial pneumonia here, but the honeycombing is not a prominent feature. You can see ground glass opacities, you can see many interstitial opacities, and you can see traction bronchiectasis, but the honeycombing is not a prominent feature. Another example of non-specific interstitial pneumonia, and you can see traction bronchiectasis, ground glass veiling, interstitial opacities, but almost with no honeycomb. One of the important findings is that this disease particularly spare the immediate subpleural zone of the lung. This is one of the helpful diagnostic criteria, but you see the full-blown picture with traction bronchiectasis, ground glass veiling, and many interstitial opacities. Then we came to the third one, which is the pulmonary interstitial edema, which means that there is accumulation of fluid in the extravascular spaces of the lung. We have two types, interstitial and alveolar edema. Then in order to remember the causes of edema in the lung, interstitial or alveolar edema, and this is the abbreviation, not cardiac. Near drowning, oxygen therapy, transfusion of related acute lung injury, neurologic pulmonary edema, allergic alveolitis, renal failure, some drugs, inhaled toxins, high altitude, acute respiratory distress syndrome, and pulmonary contusion. Then chest X-ray is the most practical and useful method for assessing pulmonary edema. In the you all know the findings of pulmonary interstitial edema, including enlarged easy hilar shadows, distended upper lobe vessels, and many reticular opacities, including B. Curlis line, A. Curlis line, and enlargement of the heart with left ventricular configuration, thickening of the fissures, and the presence of pleural effusion. And this is a good example of a patient developed interstitial pulmonary edema. This is the radiograph 10 days earlier, and this is the radiograph after she went into interstitial edema. You see that the hilar shadows are hazy and enlarged, then you can see the distension of the upper lobe vessels and many linear opacities at the costophrenic angle representing B. Curlis line, near the hilum representing A. Curlis line, and longer opacities near the costophrenic angle representing the C. Curly line. And here is an acute pulmonary interstitial edema showing the previously mentioned lines. These are the C Curlis line, and this is the A Curlis line, and this is the B Curlis lines. Then we came to one of the other causes of interstitial pulmonary fibrosis, which is the scleroderma, and this is the multisystem collagen vascular disease, and the etiology is unknown, and this is the age incidence from 30 to 50 years of age. Females are more commonly affected than males. Pulmonary manifestations are present in about 10 to 25% of patients, but lung affection is almost present in all cases at autopsy. And the manifestations are typical or similar to the usual interstitial pneumonia. And you got multiple honeycombing, traction bronchiectasis, interstitial opacities, ground glass areas. And because of the disease affects the gastrointestinal tract, and it may result usually results in motility disorders leading to dilated motile esophagus, when this will uh, uh, appear in the radiograph as esophageal dilatation, and it may contribute to aspiration pneumonia in some of these patients. This patient presented by dysphagia because of the motility disorder, and you see the reticular opacities in the chest radiograph, the ground glass veiling, and the honeycomb. Another case of scleroderma showing the classic appearance of interstitial lung disease with too many reticular opacities, minor traction bronchiectatic changes, and ground glass veiling scattered throughout the lung fields. Rheumatoid also can affect the lung, producing similar changes in the form of ground glass opacities, traction bronchiectasis, and honeycombing. In this patient, he can see some areas of air trap and emphysematous changes which are related to his long history of smoking. In cases of sarcoidosis affects the lung, and it follows the many stages in the affecting the lung parenchyma and the lymph nodes, and at the end stage or stage 4 sarcoidosis, there is complete destruction of the lung, producing similar pattern to usual interstitial pneumonia in the form of multiple honeycombing, interstitial opacities, areas of air trapping, and ground glass veiling. Some of the drugs, and I provide here a list of the drugs which may contribute to interstitial lung disease. Also, some of these or can produce changes which are similar to the non-specific or the usual interstitial pneumonia. In this chest X-ray, then you can see patchy opacity here with widespread reticular opacities scattered throughout both lung fields. And the high resolution CT of this patient receiving this drug showed areas of ground glass veiling and minor traction bronchoectatic changes and extensive interstitial opacities in both lung fields. Then we came to another cause of interstitial lung disease. We have finished with the two most common, which are the usual interstitial pneumonia and the non-specific interstitial pneumonia, which are the most common causes of idiopathic interstitial pulmonary opacities. Then we discussed the pulmonary interstitial edema. Then we passed to the collagen-related interstitial lung disease, and we provided examples um, of scleroderma and rheumatoid arthritis. Then we mentioned something about end-stage sarcoid affecting the pulmonary parenchyma. Then we discussed the drug-related interstitial lung disease, and we came to the lymphangitis carcinomatosa. And in this disease, the diagnosis is usually easy whenever you know that the patient had a primary malignancy. In the presence of a primary malignancy, the interstitial lung opacities should be interpreted as lymphangitis carcinomatosa until proved otherwise. The distribution is typically asymmetric in the lower lung lobes, and the interstitial opacities showed beaded appearance, and I will show you too. And many other findings include lymphadenopathy is not an essential finding to diagnose lymphangitis carcinomatosa, but it may be present in the mediastinum and also in the axilla. The presence of a non-primary tumor is very important for this diagnosis. Then, if you look here, this patient with esophageal malignancy with palliative esophageal stent, then presented by increased shortness of breath, then you see extensive interstitial opacities here, and this patient had the breast cancer with interstitial opacities. If you look carefully, you can see micronodules all over the opacities. In the presence of a non-primary malignancy, the possibility of lymphangitis carcinomatosa should be suspected. And here is a chest radiograph of a male 51 years old with chronic myeloid leukemia presented by recent onset of cough and severe shortness of breath. Here you can see many interstitial opacities with some prominence of the hilar shadows suggesting the presence of lymphadenopathy, and in the presence of a non-primary malignancy, the lymphangitis carcinomatosa should be suspected. This is another case where you can see too many interstitial opacities as well as ground glass veiling, and this is the high resolution CT of this patient with gastric carcinoma. And at the initial scan, you can see ground glass veiling and interstitial opacities with thickening of the interlobar fissures. And this patient was suspected to have a form of pneumonia, and he received broad spectrum antibiotics and high dose of corticosteroids. And the follow-up scan showed a progression of the disease with development of new opacities, micronodularity throughout the lung field, and the diagnosis is lymphangitis carcinomatosis. This female patient with breast cancer, non-Hodgkin lymphoma, and multiple lymphoma showed extensive reticular opacities in both lung fields, diagnostic suggestive of lymphangitis carcinomatosis. This patient with interstitial opacities, and if you look carefully and you remember the lymphatic pattern I have mentioned, and you see these nodules which represent the hematogenous metastasis. You see that the shadow of the right breast is not there, denoting that this is a breast cancer patient with lymphangitis carcinomatosis. Then we have finished with the first pattern, which is in the reticular pattern. We discussed the usual interstitial pneumonia, non-specific interstitial pneumonia, interstitial lung edema, and the collagen-related interstitial lung disease, the drug-induced interstitial lung disease, the lymphangitis carcinomatosa related to the presence of the primary malignancy. Then we came to the second pattern, which is the ground glass pattern. I have mentioned that the ground glass pattern is not a specific pattern, but it is a descriptive term which indicates that there is increase in the density of the lung with preserved bronchial and vascular markings. You should remember that anything involving the alveoli or the interstitium or both can cause ground glass opacity. So in any of the diffuse lung diseases, you can see ground glass opacities. The differential diagnosis of ground glass opacities depends on the clinical setting and other imaging findings. If the ground glass pattern is present only in the lung, then we have a specific differential diagnosis. First, this is the appearance of the ground glass pattern. You can see areas, patchy areas of increased lung parenchymal density with preservation of the bronchovascular vascular markings. In the previous days, they mentioned that this is the morphologic changes below the resolution of the CT, and they wait to for these opacities to change either to interstitial opacities. Then we go to the differential diagnosis of the reticular pattern, or became alveolar opacities. Then we go to the differential diagnosis of alveolar lesions. Previously, the ground glass pattern was thought to be due to pneumocystis carinii pneumonia if the patient is known to be HIV positive. And if the patient is known to have a lung transplantation and you got ground glass opacities in the transplanted lung, then there are one of two possibilities. Either this is a sign of rejection or a sign of cytomegalovirus pneumonia. But recently, we have a differential diagnosis for the ground glass pattern if it is present alone in the lung, not associated with any other findings like traction bronchiectasis, honeycombing, and so on. Then, considering the history of the patient and the appearance of the opacities, we have two major types of ground glass pattern. The acute one, and this is the differential diagnosis, and the chronic one, and we'll discuss later. Then the acute ground glass opacities include pulmonary edema, either due to cardiogenic edema or due to acute respiratory distress syndrome. The pneumonia, either due to viral pneumonia or pneumocystis carinii, pulmonary hemorrhage, and acute eosinophilic pneumonia. And starting by the pulmonary edema, we have mentioned we have two types, interstitial and alveolar edema. We have finished with the interstitial edema and we'll discuss the alveolar edema in the alveolar pattern after that. Then we came to the acute respiratory distress syndrome, which indicates an injury to the lung leading to pulmonary edema and diffuse alveolar opacity. This acute respiratory distress syndrome can affect any age group, and the patient presents by severe respiratory distress, and they, the chest radiograph will show patchy ground glass opacities or even areas of consolidation, and the distribution is usually in the dependent lung regions. These are the predisposing factors of acute respiratory distress syndrome, which are more or less similar to those that are contributing to acute alveolar edema. You remember the not cardiac. And here we have the hypovolemic or hemorrhagic shock, the septic shock, burns, acute pancreatitis, heroin, and other um, uh, drug overdose, disseminated vascular coagulation, chlorine gas, nitrogen dioxide inhalation, massive viral pneumonia, fat embolism, near drowning, and massive aspiration of gastric contents. Then to differentiate the acute respiratory distress syndrome from the cardiac edema. Number one, no cardiomegaly here, no pleural effusion here, no B. Curlis line here. Evident air bronchogram, which is not present in the cardiogenic edema. Then the onset may be delayed about 12 hours after the patient has exposed to the insult. Between 12 and 24 hours, you got patchy alveolar opacities in both lung fields. Then within 48 hours, you got massive airspace consolidation. Within 7 days, you got some clearance, which is usually attributed to ventilation rather than the true healing. And after 7 days, it's starting the permanent lung damage with which may progress to fibrosis. Then the patient may have a superimposed pneumonic consolidation, and this is judged by the presence of new opacities in the lung and the presence of pleural effusion. These two issues may indicate that the patient has been subjected to a superimposed infection. One of the measures for treatment of these patients is continuous positive airway pressure, and this has some complications, including pneumothorax, pneumomediastinum, and pulmonary interstitial edema. Then we came to the pneumocystis carinii, and now is known as pneumocystis jirovecii, and this is an atypical pulmonary infection, almost confined to patients with AIDS or HIV positive patients. And pneumocystis pneumonia is, according to the literature, never present in an immune competent individual. The diagnosis is confirmed by the bronchovascular lavage, which is sensitive in about 90% of cases. High resolution CT will show the opacities that may not be seen in the chest X-rays. The high resolution findings in patients with pneumocystis jirovecii or pneumocystis carinii include ground glass opacities in about 40% and nematoceles in about 30%, and these nematoceles are subject to rupture with a risk of pneumothorax. Pleural effusion is rare. Lymphadenopathy is uncommon, which is present in about 10% of the patients. And if you know that this patient is HIV positive, you should interpret the changes in the chest X-ray and the CT scan on this basis, and you consider in your mind the possibility of pneumocystis pneumonia or pneumocystis jirovecii. Uh, uh, as I have mentioned before, in this particular type of infection, The clinical data are very important to know that the patient is immune compromised or an HIV positive patient, and you may got ground glass opacities, too many nematocytes, areas of consolidation, and you may see some air bronchogram. And this patient is a woman undergoing steroid therapy for collagen vascular disease. And because of the age and the steroid therapy, this patient is maybe considered as an immune incompetent. And you got many opacities in the lung with some air bronchogram and areas of ground glass veining, and this was proved to be pneumocystis pneumonia. Then we came to the acute eosinophilic pneumonia, which is, from the radiographic point of view, pneumonic consolidation, which is usually extensive and patchy. And this pneumonic consolidation is uh, intimately related to the presence of eosinophils in the bronchoalveolar lavage and in the blood. The exact cause is not well known, and the response to corticosteroids is dramatic. Then you look here, this is the chest radiograph of a patient um, with alveolar and interstitial infiltrates. This is the follow-up radiograph obtained 3 months after corticosteroid therapy, and he got complete resolution of the disease. Then this is a type of pneumonia, but the cause is not known. In the X-ray and the high resolution CT, you got random distribution, bilateral ground glass opacities, interstitial septal thickening, pleural effusions are common. You see here bilateral pleural effusion. If you look carefully, also you can see the crazy paving appearance. Airspace consolidation in 50% of the cases, centrilobular nodules, may be seen in about 30% of cases. Then this patient is male, 18 years old, with known to be asthmatic and smoker, presented by fever, productive cough, shortness of breath for 2 weeks, and he is unresponsive to antibiotics. And this is one of the leading uh, findings that may help you to think of particular types of pneumonia, like this one and the coming one, which is known as cryptogenic pneumonia. Then the uh, the non-response to the antibiotics may drive your attention that this is not an ordinary pneumonia, and then you think of other types of pneumonia, and this is the follow-up chest X-ray after corticosteroid therapy. This patient with bilateral ground glass opacities and consolidations with minimal pleural effusion seen in the CT scan, and you see left-sided pleural effusion. Then the differential diagnosis include these types of infection, and these types of infections are suspected based on the inadequate or the the unresponse response to the antibiotics. You consider eosinophilic pneumonia or cryptogenic organizing pneumonia or an atypical finding, a typical type of infection. And CBC showed significant eosinophilia, and bronchoalveolar lavage showed significant eosinophilia. Then you are dealing with acute eosinophilic pneumonia. Then if you have vagiopacities in the lung, and you thought that these are pneumonic consolidations, and the patient is treated by antibiotics with no response, then think of another type of pneumonia, particularly the acute eosinophilic pneumonia, the cryptogenic organizing pneumonia, and one of the atypical infections. And this is the follow-up of the same case. You see the opacities, and 10 days after corticosteroid therapy showed complete resolution of the disease. And this is an important issue, the fact that marked improvement of the patient clinical and radiographic findings after corticosteroid therapy make the acute eosinophilic pneumonia the most likely diagnosis. هذا وبالله التوفيق والحمد لله رب العالمين.